Okay, hi everyone, and welcome to today's Irish Cancer Society Research Online Talk. My name is Clara Stein, and I'm a research coordinator here at the Irish Cancer Society. And it's great to see so many of you here. Thanks so much for joining us during your lunch break and busy days, I'm sure. And I'm delighted to introduce you to Dr. Maria Pertl, and hopefully Katie Verling will be joining us at a later stage as well. Maria is an Irish Cancer Society funded researcher and lecturer in the RCSI Department of Health Psychology. And Maria will be joined by Katie, who is an experienced PPI researcher. Katie has been involved in cancer research for many years and has lived experience of cancer and depression, contributing a hugely important perspective to this research. And I can see she's just joined us there. Welcome, Katie. And Katie has contributed to a range of research projects across RCSI, the Health Research Board, and the HSE. So we're delighted to have you both. Thanks for being here. Maria and Katie and their team are currently investigating how to best manage depression among people living with cancer. And although depression is common in people living with cancer, many people do not receive adequate treatment. So this is a really important area to research and address, as both depression and cancer can impact on various aspects of daily life. Today, Maria and Katie will provide an update on their research exploring the different treatment options for depression available to people living with cancer and the factors that support effective depression management. Just a quick reminder that the webinar will be recorded today, and if you have any questions for Maria or Katie, you can write them down in the Q&A box that you should be able to see at the bottom of your screen, and we'll get to all of the questions at the end. And I would also like to remind everyone that this will be a research talk, meaning that none of us here are qualified to provide any medical guidance or advice. So please ensure that you don't disclose any personal health information in your questions to Maria and Katie. Maria and Katie will be happy to answer questions that are relating to the research or more generally to the topic of depression in the context of cancer, but they won't be able to provide any personalized or medical advice. So without further ado, I will hand it over to you now, Maria and Katie. Thank you.
Thanks so much, Clara, and thank you to the Irish Cancer Society for inviting us to present today. So Katie and I will present a research update on managing depression in cancer, and mainly we'll be talking about the findings from the ENHANCE project, which was a research study that was funded by the Irish Cancer Society and the National Cancer Control Programme. And ENHANCE stands for the effective management of depression among patients with cancer. So I might start with just to give a little bit of context to the study and why we focused on this. So we know that depression is more common among people who have been diagnosed with cancer than in the general population. We also know that untreated depression can have a very negative impact on quality of life. It can impact on patients' satisfaction with care and their ability to participate in their cancer treatment and adhere to the treatments. And it's also linked with higher levels of anxiety, pain, and fatigue, and has implications for healthcare costs as well. So it's really important that depression is identified and that patients have access to evidence-based treatments that are effective and acceptable for patients with cancer. There are lots of treatment options available for depression, and lots of research has also examined the effectiveness of these treatments. But up to now, no one has compared them all. So it's not clear which are the most effective and which are the most acceptable for patients with cancer. So that was really the aim of the ENHANCE study. So the ENHANCE project consisted of two studies. The first was a review of the existing literature to identify which intervention approaches are the most effective for patients experiencing depression in the context of cancer specifically. And then the second part of the project was a focus group study with patients and healthcare professionals to get their views of the findings from the review and to also explore the factors that impact on the effective management of depression in the Irish healthcare context. So this was the Enhance project team. So it was a real team effort. So I'll be presenting on behalf of a group of people who were working on this for a number of years, and really importantly, to highlight just the input that Katie and our other PPI co-researcher Garrett had on the project. So I'll be leading the presentation of results, but Katie is going to jump in um, throughout the presentation, probably to kind of clarify what I'm saying for everybody, and to add her perspective and experience of working on this study as well.
Hello, everybody. Just a second, Maria. I want to explain I've had loads of problems with my computer and now with my phone, so I can't turn my phone off. So I'm listening to myself on the phone and online. But I just want to say that
Yeah.
I have really, really enjoyed being involved with this and have learned a huge amount. I knew nothing about research before I started this. And thanks to Maria and her team, they have guided myself and Gareth through the enormous amount of learning involved in just how research is done and all the stuff to do with statistics and all that. But it's we engaged with this because we wanted other people to benefit from our lived knowledge of experiencing of depression and cancer. And that was what we desired, that coming out of this research, that there would be greater security in knowing that very good research had taken place. And we could say to people, well, I've been involved in this project and I know that this or that is better than that or the other. So that was the kind of point of departure for us as patient participants. Over to you, Maria.
Thanks so much, Katie. Well, the learning was definitely mutual, and the project would have looked very different without the input of Katie and Garrett. And they were involved from the very start, and are still involved now as we're finishing up the project. And it's really been invaluable. And so they were really an integral part of the research team. Okay, so the Enhance project, I'm going to discuss the two aspects of it in turn. So the first was a systematic review, and we wanted to carry out a network meta-analysis to examine which intervention approaches are the most effective for treating depression in the context of cancer. So I know not everyone may be familiar with the term network meta-analysis. So just to provide a little bit of context for this. So a systematic review is a structured and comprehensive way of bringing all the available research evidence that has been carried out to date together to answer a specific question. So it's finding all of the studies on a given topic and then summarizing those in one review. And most systematic reviews, or many, would include a meta-analysis as part of that. And a meta-analysis it's a statistical method that's used to combine the results from lots of different studies together to answer a specific question. So for example, the question might be, is psychotherapy effective for treating depression? And the network meta-analysis is kind of a step up from that. So this allows you to combine and compare findings from multiple treatments, even if they haven't been compared directly before. So you might have trials looking at psychotherapy and trials looking at the effectiveness of antidepressants or exercise. And even if those interventions haven't been compared head to head in one randomized controlled trial, a network meta-analysis allows you to bring the results from all of those studies together, and even to generate a hierarchy of which treatments are the best or the second best, depending on your outcomes of interest. So, the first thing that we did, the first step that we had to do, excuse me, was to decide on the inclusion criteria for the studies that we plan to include. And we had lots of discussion here within the research team, and our PPI researchers, Katie and Garrett, played a big role here in really deciding on, what studies we were going to include in this review. And we went back and forth on this a lot. So ultimately, we decided to focus on randomized controlled trials that included adult participants who had a current or previous diagnosis of cancer and experienced elevated symptoms of depression at the time. And all of the studies examined the effectiveness of an established intervention approach for managing depression. And again, Katie and Garrett were really important. I don't know, Katie, do you want to jump in here and speak a little bit about the types of interventions we included?
Between Garrett and I, we'd had experience of psychotherapy and pharmacology, and we had been forced to do exercise at times, and there'd been different types of things. But we did think that we really wanted complementary therapy to be included in this list, because as somebody who is ill, you get an awful lot of advice from people who are telling you to try this and that remedy, and those who would be critical of pharmacology, to say maybe you should give up the tablets and try following a nature cure and take hot baths and go for forest bathing or something. So to be able to take that on head to head, to say, well, look, include complementary and alternative therapy, because it is really it is one of the things that is said to one when one is feeling very unwell and confused about what is happening. So it was worthwhile including it, even though I think there were very few studies in that area.
Yeah, thanks, Katie. So we had been a little bit on the fence about complementary approaches, but Katie made a really strong argument for that. So it really shaped the protocol for the study then. So we registered the protocol for the systematic review. So the protocol is, I suppose, a bit like a recipe for the study. So you set out how you plan to carry it out. And it's really important that you publish that recipe and make it available online before you actually carry out the study, so that you're kind of beholden to it. So just very much in brief how we carried out the review. First of all, we did a database search to identify all of the studies in this area, and then we looked through those search results to identify the ones that met the inclusion criteria. And we identified 70 randomized controlled trials that met the inclusion criteria we had set out. And that was quite a lot more than we expected. So we were very optimistic about the study and about comparing the effectiveness of the treatments, because we weren't expecting to find 70 trials. And then once we had those trials, we extracted all the necessary data from those. So both in terms of the results that they reported and information on the trial quality. And then we evaluated the reliability and the integrity of those trials using established measures and analysed the results. So what did we find? Overall, there were 70 trials and they included 148 trial arms. So the reason why there's maybe more trial arms than studies is most studies would include one intervention group and one control group, but some studies had two intervention groups, so they might have included pharmacology and psychotherapy treatment arms, for example. The most common treatment arm was psychotherapy, so that was studied the most, but we had across all of the different approaches that we were interested in. In total, the 70 studies included nearly 7,000 participants who took part in those trials. So 6,831 participants took part across the 70 studies. And a really important point as well is that the majority of the studies were published fairly recently. So 70% were published since 2015 and 43 published really in the last 4 or 5 years. So a very recent literature, and that's an important point that we'll come back to later. So a really important aspect of carrying out a systematic review like this is to assess the trial quality in order to determine whether the data from the trials are at risk of bias, so whether the results might be biased for one reason or another. And to do this, we used a standard tool called the Risk of Bias 2, the ROB2 tool, to assess how reliable the results from each trial were. And this tool has 5 different domains that each relate to an important aspect of trial design, and they feed into an overall rating of risk of bias that's either low risk, some concerns, or high risk of bias. And Katie came up with a really great analogy for understanding why a risk of bias tool is important that I have used in every presentation since then. Katie, do you want to describe your interpretation of it?
Yeah, because I was struggling to understand how these things work. I say I have no science background, and eventually I realized it was really like working with a sieve when you're putting so many things into a sieve and you want to get just the certain bits of it out. And so the sieve has been the kind of method in my mind of how to literally sieve through information to get stuff that is valuable and then discard the rest. So we've been using that. It's like a filtration system effectively, and this is how I see risk of bias working as a tool.
Yeah, and it works really well. So what a lot of systematic reviews would do is they would use this kind of the risk of bias tool as the strainer to sift out the studies that are really high quality and have a low risk of bias. And then often what they do is compare the results when you include all of the studies, including the ones that have high risk of bias, to the results for when you only include the low risk of bias trials. And that allows you to see whether the results are affected by trials that have the potential to have risk of bias, so that have a risk of bias to them. And it's really important to do that because we want the results that we're presenting to be reliable and trustworthy. So what did we find when we applied the risk of bias tool to the 70 studies? Well, it was quite disappointing. So of the 70 studies, we actually only identified one study that had a low risk of bias, some that had some concerns, and then actually the majority had a high risk of bias. So if we go back to the strainer analogy, then you can see clearly that this led to a problem for us because we were only left with one study that had a low risk of bias, and we can't compare the effectiveness of various treatment approaches when we only have reliable data from one study that evaluated just one intervention approach. So what to do next? Well, as we thought, we had two options. The first was to compare the treatments anyway, using the data from these 70 trials, even though they were of poor quality. But that, of course, would mean that the results are undermined by the serious risk of bias. The second option then was not to compare the treatments because it wasn't possible to include only those with low risk of bias because that was one study, in which case we couldn't actually fulfill the study objective and identify the most effective treatments, which is what we had set out to do and the whole purpose for the project. We felt very strongly that we had a duty to present robust findings that aren't misleading and that are based on reliable evidence. And that's why we went with option 2.
Can I come in here, Maria? Just one thing.
Absolutely, Katie. Yes.
I think this was a particularly fascinating point for Garrett and I, because I say we'd engaged with this process in order to find out what were the better ways of dealing with depression and cancer. And we were shocked with this response, with this result, even though we trusted it completely. And we were very, I think, engaged, maybe even vociferous in arguing for not comparing studies that were dubious in terms of bias or whatever. We really had to make this known. It's very disappointing from a patient point of view that so far there's only one study that would recommend one particular way of treating depression and cancer. And so we were very exercised by this. This was just our contribution.
Yeah, absolutely. And yeah, it was very disappointing because we couldn't do what we ultimately set out to do. But I suppose we're very cognizant that the findings from systematic reviews like this are used to inform clinical guidelines, and we didn't want to be contributing to information that wasn't reliable. We did question whether we can learn anything about treatment effectiveness from these trials because I suppose it's really important to point out that running trials like this is really, really difficult, and some minimal risk of bias may be justified in that context because it's so difficult to carry out research like this. And a lot of it was, was carried out by very well-meaning clinicians who wanted to find better ways of supporting their patients. So we did look at the trials that had minimal risk of bias concerns, and there were 4 trials that supported the use of collaborative care compared to control groups that didn't receive the collaborative care intervention approach. And one of these trials had a low risk of bias, and the other 3 had very minimal concerns that really related to how depression was assessed. And it's very difficult with studies like this because depression is, patients have to report the symptoms, but if they know what intervention group they're in, then that can introduce bias that way. So some of the issues around risk of bias then are that it's very hard to get around some of the risks that are there. So we did consider those trials, and we found that there were 4 trials there that were methodologically very sound, aside from the self-report issue there, and they do support the use of collaborative care and show that it is very effective for managing depression. But we also found that in broadening out what is an acceptable risk of bias, then included some studies that seemed to report results that were very suspicious, so that almost seemed too good to be true. So we were very cognizant as well that, if we broaden out what is an acceptable risk of bias, that we might then also be introducing bias ourselves to the process because we're not adhering strictly to the measures that are there. So we considered, is there another way to potentially identify problematic studies that might be, that are reporting some results that might be too good to be true? And that led us then to do a research integrity assessment. So a research integrity assessment that we used was a very recently developed tool that basically allows you to investigate how trustworthy a study is. So while the risk of bias tool helps you to consider whether the data from a trial might be biased because of the methods that were used, research integrity is about whether the researchers adhere to ethical and professional standards. And it considers aspects such as whether the authors registered the study, so whether they published the recipe they were going to use for the study ahead of time, whether they had and sufficiently reported ethical approval for the study, characteristics of the author group, for example. So, for example, you would expect numerous authors to be involved in a randomized controlled trial. So if you have very few authors publishing a large trial, that's suspicious. And then also questions around the plausibility of the methods and the results as well. So, like the risk of bias tool, the research integrity assessment has several domains that contribute to an overall integrity judgment. And when we applied this to the trials that we included in the review, we found that most failed the integrity assessment as well. So there were only 10 trials that had no concerns, and many that had concerns on several different domains. So really those findings validated our decision not to run the analysis comparing the treatments. So what are the key findings from the review then, given the research integrity and risk of bias findings? So I suppose the key finding is that it wasn't possible to identify the most effective treatments for depression based on the current literature because the existing trials we have are at risk of bias and are of questionable integrity, mostly, not all. So really it points to the need for better quality trials to answer this question. And I suppose an important point as well is that it's almost standard practice now to do a systematic review, find that there are problems with risk of bias, and analyse and present the results anyway. So when we published the paper, we really wanted to highlight the fact that we intended to do a network meta-analysis and statistically combine all the findings, but that it wasn't appropriate to do that because of the nature of the literature. And that's why we included, when we were titling the paper, we made that point in the title that it was an attempted network meta-analysis, because we really wanted people who were interested in this methodology to read this and say, okay, that we're kind of drawing a line in the sand to an extent. So if anybody wants to read the paper, the QR code there will take you to it. It's open access. And I suppose our decision not to quantitatively synthesize the results from all the studies was really validated then when we went on to do the qualitative study, where we asked healthcare professionals and patients about what they thought of the findings from the review. It was interesting that a lot of the healthcare professionals weren't really surprised, because they had noticed this in the literature themselves, and they really recognized the need to have accurate data, and they supported the decision not to run the analysis. So as one healthcare professional said, when you run the analysis, you can't put the rabbit back in the hat. So once you run it and you publish it, people are going to take that result, and they're not necessarily going to couch it in all the caveats that are needed. And patients likewise really highlighted the need to have accurate data to base their treatment decisions on. So one patient said it's important to get the correct data, to be comfortable and confident with your data. I work in finance. I couldn't do research and have one or two numbers wrong. It has to be 100%. And then recently, an editorial was published in the Journal of Psychosomatic Research, which focused on our review and really validated our decision not to proceed with the analysis as well. So really highlighted that we need to have this methodologically rigorous approach to kind of reshape how we do research and inform clinical practice. So that was great to see as well. So just to highlight some of the implications from the review then, I think the most important point to point out is that the findings don't mean that these interventions for depression do not work. It just means that the research evidence is not good enough. So we do have reliable evidence that collaborative care is effective for treating depression. And we know from many patients and healthcare professionals that the other treatment approaches are really valuable as well, but we just don't have high quality research evidence to support that yet, specifically in the cancer context. So most of the implications then are for the research community, really, that we need to do better. But the onus for that isn't just on researchers, but also on publishers and funders and ethics boards as well. So we know that doing randomized controls like this takes a huge amount of money and resources that historically haven't really been available to psychosocial research. And a lot of the research was carried out by people who were really trying to improve things and find evidence to improve patient care. So we need to support research like that, but we need to make sure that researchers are able to adhere to the research and reporting standards and the safeguarding practices around this. So, for example, adhering to guidelines for pre-registration, publishing your recipe for the study ahead of time. This is new, it's around since 2005, but it's still not enforced. So we need to change that. And the same with reporting standards. So the Consort published guidelines around reporting standards in 2010, but many studies are being published that don't adhere to those, and that makes it really hard then to figure out, well, what's trustworthy, what's at risk of bias and what isn't. So we have to make sure that we change those research practices, and for researchers then that they consider the implications, of how they design their studies and what that means in terms of risk of bias, and then for reviews as well, to use integrity tools to screen out studies that are of questionable trustworthiness or potentially at risk of bias, so that we don't keep perpetuating findings that are not reliable. So there are the findings from the systematic review. Katie, did you want to jump in there before I go on to the ENHANCE project, or is there anything else you'd like to say?
I just want to say that it has been wonderful to be part of this team, for the simple reason that for the patient voice to be taken on a kind of an equal voice, equal status in the research team. Yes, we're not bringing any sort of research know-how to the project, but what we keep on kind of reminding the researchers is that, remember, it's for us. It's for people who are suffering from depression and experience cancer or have experienced cancer. So it's, at the risk of being a pain in the ass, which we may have been at times, it was that
Absolutely
remember
not.
who this is for, remember who this is for. And that's all that's well and good. And I'm delighted that's the network meta-analysis. But how does this work for the patient? How do we benefit from this? And it did appear, it's my first time ever being involved in a piece of research like this. It really did appear that having the patient voice included, and two different patients with, two different types of experience and two different personalities, is that actually adding that to the whole research process did seem to make it richer. And it certainly was more satisfying from our point of view, that we felt we were giving meaning and depth and value to the process, to the research process.
Absolutely. Thank you, Katie. You really did. And when the results kind of didn't go as we had planned, played such a key role here in terms of, refocusing me essentially and saying, no, Maria, what you have here is really important. It's as important as if you had been able to do the analysis. And so, what the editorial said then, you and Garrett were really saying that the whole time, underscoring the importance of it. So that played a really key role as well. So I'm going to move on now and talk about the second part of the study that involved focus groups with patients and healthcare professionals. So the aim of the focus groups was to get their views of the findings, which I've touched on a little bit, and then to explore their views and experiences of these intervention approaches with the view to identifying the factors that impact on the effective management of depression. So 25 healthcare professionals and 10 patients took part in 9 online focus groups. And I suppose, so the aim of the analysis that I'm going to present today was to examine the factors that impact on the effective management of depression among patients with cancer in the Irish healthcare context specifically. And we used 2 theoretical models to help guide the analysis for this question. And they really spoke to 2 kind of key questions. The first is, what does effective management entail? And for this, we used a framework called the AAAQ framework, which is a WHO framework. And it really asserts that for effective care, you need 4 essential elements: availability, accessibility, acceptability, and quality. And together, they enable you to deliver effective care. The second question was, what types of factors impact on the management of depression? And for this, we used a model called Bronfenbrenner Socioecological Model. And this is really a tool for helping you to organize a very broad array of potential contributing factors that may impact on health across multiple levels that span from individual factors that are specific to a given patient, for example, to broader environmental and contributing factors. And I think this model, it looks really complicated here in the diagram, but I think it's best explained with an example. So bear with me while we go. We use another baking analogy here. So I want you to think about all of the factors that influence baking a good cake. So in order to produce a good cake, your individual skill as a baker is going to be important. So your past experience of baking, your motivation to bake on a given day, your skill level to bake, they play a role. But you also need good ingredients. So you need to have those ingredients available to you. You might need eggs, flour, sugar, butter. And the quality of those ingredients is going to impact on the taste of the cake as well. But it's not just the ingredients, but also how those ingredients work together. So for example, you can have sugar and butter, but if they're not creamed together properly, then it's going to impact on the texture of the cake. So how they work in concert with one another is important too. Then if you go a bit more broadly beyond that, looking at the environment as well, the type of kitchen that you're preparing the cake in, how good your oven is, whether it's working properly, is going to impact on how well the cake is baked. Whether you're using a good, well-tested recipe will also make a difference. And then more broadly beyond that as well, the cultural context is important. So for example, what even is a good cake? So my view of what a good cake is, I come from Austria, might be very different to your conceptualization of what a good cake is. Or, you could ask more broadly beyond that, should we even be making cake? Should we all be focusing on bread instead? So social cultural norms can also kind of impact on your on the factors that influence whether a cake is good or not. And then finally, you also have changes over time. So for example, your skill level as a baker might change over time, but you also have different environmental factors that change over time. For example, technological advances that impact on the types of recipes that are available to you, or whether you use an old recipe book or whether you have a fancy app that lets you figure out what the best recipe is based on the ingredients you have. So all of those factors impact on the final product. And that essentially is what Bronfenbrenner is saying with the socio-ecological model, that you have a whole host of different factors across a spectrum of different socio-ecological levels that impact on the outcome. So on an individual level, you have things like the personal resources available to someone, their attitudes to healthcare and to the condition they're diagnosed with, their personality, their health status, their previous experiences play a role. The microsystem then considers close spheres of influence, so like the ingredients. So these are the health professionals possibly who are involved in your care, the family resources that are in your close sphere of influence and the role they play in supporting you. The mesosystem then is the next level. And this looks at interactions between the diverse everyday spheres of influence. So for example, what's the level of coordination and communication like between all the different healthcare professionals who are involved in your care? And the exosystem then beyond that looks at broader environments. For example, the healthcare system in which you're being treated, the healthcare policy in your country, and even things like the media and how they shape that broader media environment shapes the immediate environment that you're treated in. The macro system then considers shared cultural and social context. So for example, social discourses and attitudes around the condition and its treatment. And then finally, shifts and transitions over time. And this might be things like changes in policy, changes in healthcare policy, or even changes across a treatment trajectory would be considered in the chronosystem. So this model is really useful because it provides a kind of conceptual and methodological tool that allows us to organize a really broad array of potentially different contributing factors that influence outcomes across all these multiple levels. And it also allows you to explore possible interactions between factors, both within and across those different levels of influence. And that's important because if we can do that, then we can try and identify leverage points for health promotion that we can target when we're trying to change the system. So I hope that that makes sense, that kind of a baking analogy. So what I'm going to do next is to consider some of the themes that emerged from the qualitative focus group data relating to each of these levels of Bronfenbrenner socio-ecological model. So starting with individual factors, a really key theme that emerged here was people's internal and external resources that were available to them and how they impacted on the accessibility of treatments for depression. So, for example, personal finances played a big role. It was a consistent theme about how expensive cancer is. That, yes, some supports for mental health were available to patients, but if they wanted to continue to avail of psychotherapy over a course of weeks, or avail of complementary and alternative approaches to supporting their mental health, that was really expensive, and that really prohibited some people from engaging in continued support for their mental health. In terms of internal resources, a key theme was around people's self-care agency. Sorry, I'm talking about this and I forgot to move on. Um, so patients really highlighted that they had to work really hard to advocate for themselves, to access treatments, to find out what was available to them, and to engage with that on a continuous basis. So, for example, one patient said, "I'm managing mental health is massive for me. For me to enjoy the life I have, thanks to the treatment I'm on, I have to work so hard at my mental health, and it's hard, it's hard, it's hard work every day. I have to do something." So they really felt that responsibility, and there was a sense that if they didn't step up and do this for themselves, no one else was going to come in and do it for them. And there was real recognition among healthcare professionals as well, that that ability for self-care, to self-advocate, that not everybody had that. And especially because here we're talking about people who have who are experiencing depression, and that makes it really difficult for people to self-advocate. So people who had very severe symptoms of depression, they weren't always able to speak up for themselves and to seek help. So that really impeded access to effective management. Interestingly, as well, knowledge from previous experience of depression actually seemed to play a bit of a protective role. So we know that depression prior to cancer is a risk factor for experiencing depression in the context of cancer. But patients who had experience of depression prior to cancer actually had more knowledge that helped them to advocate for themselves, because they were able to recognize maybe beforehand, or they were able to recognize quicker that they were experiencing symptoms for which they needed support. And they were also familiar with the treatment landscape. So they kind of knew that the treatments already, the treatment options that might be available to them, and what might work. So it actually played a bit of a protective role here. Another theme that emerged in relation to individual contributing factors was people's perceived entitlement or worthiness to avail of resources. And that kind of limited the availability of treatments for them. So sometimes people felt that they had overused resources, or that they had accessed some resources for supporting their mental health that maybe were free, and then they felt they weren't entitled to continue using them. And they were very aware of the fact that resources for supporting mental health are really limited, and they didn't want to kind of overstay their welcome. And sometimes that was communicated to them if they were asked, "Oh, you've had 6 sessions of psychotherapy already," and they might have perceived that as being, well, they're not entitled to more. And they were very cognizant of, not wanting to overuse limited resources. So, for example, one patient said she stopped going to the cancer centre because she felt there were people who needed it more. So she was self-limiting her access to mental health support. And then finally, there were views on treatment appropriateness and personal fit as well, and they impacted on engagement because people mightn't have always viewed the treatments that were recommended to them as acceptable or appropriate for where they were at in the treatment trajectory. So this came out a lot in relation to antidepressant use, of pharmacotherapy for depression, and exercise as well. So patients sometimes felt that, they were just told to exercise, but that wasn't structured or scaffolded, and they just felt that it was completely beyond them. Or some people felt that it wasn't actually a treatment approach for depression. And so they were given very limited support around that, and that impacted then on, how acceptable they viewed it as a treatment. So I'm going to move on then to microsystem factors. So again, these are close spheres of influence, and the key theme that emerged here was around around the capacity and capability of treating healthcare professionals to support the mental health um, of patients who were experiencing depression. So a lot of kind of sub themes here around, a lack of awareness and skills in providing psychological support among people involved in cancer care. Not always, but sometimes, and the need for specialized psycho-oncology care. Patient navigators played a really big role in terms of helping patients to navigate the healthcare system and signposting supports. Also, things like the need to tailor interventions for patients because of the complexity of factors that can feed into depression in the context of cancer. And really kind of a lack of understanding of the impact of cancer on mental health and failure to tailor it to the patient or address patients' basic needs. So, for example, one patient said, I had to go to my GP numerous times to try and explain why I was struggling, to justify myself. So sometimes patients really felt that, there was an expectation of them to be well, especially post treatment, and that there was very limited understanding of why they were continuing to have these symptoms of depression. And healthcare professionals really highlighted the importance of having specialized experts in psycho-oncology because of the difficulty of unpicking all the contributing factors to depression in the context of cancer, and the need to have specialists who really knew what they were talking about and were, experts in this patient cohort, so that they could identify the most appropriate treatments for a given patient. The availability of treatments through cancer organizations and charity also came out really strongly in the results as well. So patients really spoke about, that they were able to access treatments for depression that they just wouldn't have been able to access otherwise without these being available through charitable organizations. And they spoke about the range of different treatments that were available to them that wouldn't have been because of the cost and because they weren't available in their treating centres. And then finally, peer support and knowledge also played a huge role in terms of supporting accessibility and acceptability of treatments. So, for example, one patient said, you really have to seek it out. That's why support groups are fantastic, as people say, oh, go here, go there, but it's not coordinated. So patients kind of worked as patient navigators for each other in order to signpost different treatments and supports that were available. In terms of the meso system then, so this is looking at interactions between diverse spheres of everyday influence. The key theme here was really, the difference it makes when a care system is integrated versus fragmented. And that really impacts on all of the different elements of effective care in terms of availability, accessibility, acceptability, and quality. And key sub-themes here were around, the need for collaboration, communication, and coordination between different healthcare professionals who were involved in care, and the problems that can arise when that communication isn't there. So, for example, it has to be collaboration between your medical team, your GP, your psychologist, psychiatrist, and other services, because you're one person. You're one person, you're not one person with 10 different parts like in the system. You're one human being. And that really wasn't reflected for patients in the care they were getting, which was sometimes very fragmented between going to the oncologist for this, going to the nurse for that, and psychiatry and GP. So it was very very fragmented a lot of the time with no communication. And healthcare professionals highlighted this as well, and highlighted that sometimes people weren't really, they were unsure where to send patients. So there was a lack of mutual awareness of the resources that are available, because there are lots of resources available, but sometimes patients and healthcare professionals don't actually know about them and then aren't directing patients to go. And especially the lack of kind of communication and coordination between primary care and hospital care came out quite strongly. So just a little conscious of time, so I'm going to just fly through some of the ecosystem factors. So these are broader environments that affect the immediate environment, and lots of different themes came out in relation to this level of influence that impacted on the availability of care, the accessibility of care, the quality of and the quality of care. So, for example, lots of themes around the geographical distribution of services and how sometimes it seemed like a postcode lottery in terms of what patients were actually able to access based on where they were treated. The reliance on the charity sector to provide support for mental health support came out as a big theme as well, that, you know, a lot of the time patients aren't able to access it through the public healthcare system, but you know, there was the expectation that the charity sector would make up for that shortfall. And in terms of quality, a really key theme was around GDPR and the lack of the absence of electronic records and the impact that had on quality of care, that things were falling between stools, that there was little coordination, and there was no space then for healthcare professionals, or no time for them to really ask about psychological support and mental health and well-being, because they were kind of catching up on you know, what a patient what treatments they had received. And patients were really concerned that, you know, if it was up to them to kind of inform everyone of the treatments that they were getting, and they were not able to remember it a lot of the time, that that might really impact on the quality of care and safety as well, because of the absence of the ability to share data across different healthcare professionals. And another key theme in relation to the ecosystem was around the psycho-oncology model of care, and the really positive impact that this has had in terms of directing the care of oncology patients who have depression, and you know, that this really had such a significant impact in terms of increasing the availability, but also the accessibility and the quality of psycho-oncology support that is available in Ireland. In terms of macro system factors then, so here we're considering the shared kind of cultural and social context. A key theme was around the prioritization of physical over mental health, and how that limits the availability and accessibility of supports for mental health. So, you know, these kind of discourses around that the focus is around curing cancer and everything else is secondary to that. But for patients, mental health was really a fundamental part of their well-being, and they felt that it should be on a par with treating the physical disease. And social discourses around cancer also kind of impeded or limited people's ability to seek help, because it kind of put pressure on them to suppress or dismiss negative emotions. So this idea that you're meant to feel lucky, psychologically, you're meant to feel lucky. Sure, aren't you alive? Aren't you able to do this? Aren't you able to do that? And then there was some interesting discussion around gender roles and expectations as well, and how that can limit help seeking too. So, for example, one patient said, you know, as mothers, we have to keep on pretending, you know, even on the best of days, even in normal life beforehand. You don't want just your children to see you struggling. And then finally, the chrono system looked at shifts and transitions over time. And one of the kind of key themes that emerged from this was around how transitions across the cancer care journey impacted on the accessibility of psychological support. And that was very clear that after patients finished the acute phase of their treatment for cancer, a lot of the supports fell away. So as this patient says, as soon as my last appointment finished, medical appointment finished, that was it. Everything stopped, no care, nobody checking in. I had to go on my own. You're cast adrift. So there was a real sense that there were supports while they were in the hospital, while they were linked in, but then afterwards there wasn't sufficient support. And that's often when people needed support for their mental health the most, when the cancer treatment was finished. An interesting theme also emerged around the changes in the perceived need for psycho-oncology over time, and improvements that have kind of come about through patient advocacy and changes to policy like the psycho-oncology model of care, but also recognition that this is relatively new because improvements of treatments have meant that people are living longer with and beyond cancer, and that because of that, there's greater recognition now of the need to support patients' mental health. And then finally, also discussion around how changes in the contributing factors to depression can vary across the cancer care journey. So the factors that lead someone to experience depression on diagnosis and through treatment might be different from the ones that are impacting on depressive symptoms after cancer treatment has finished, and how there's a real need to tailor the treatment approach to where a patient is at and the unique contributing factors to their depression at that specific point in time. So now it's a bit of a kind of a roller coaster tour through lots of complex themes and ideas. But I hope it gives you a sense of just the multitude of factors across all of these different levels that influence the different elements of the effective care for depression, or effective management of depression, and that they impact on the different elements like the availability of care, the accessibility of care in nuanced ways. So if we want to support the effective management of depression among patients with cancer, it really underscores the need for an integrated model of care that requires a whole systems approach to optimize all of the different systems of influence. So if you think back to the kind of cake analogy, if you think about all the factors that feed into making a good cake, we have to optimize all of the influences across the spectrum of factors. And what this model allows us to do is then to identify different leverage points that really tie into those contributing factors on each level. So, spanning from the individual right through to kind of the wider social discourses. And I'm aware it's 1:00 now, so I can leave this as the last slide. I can leave this up there. I've just included the baking analogy here. And I can talk through the implications and the different kind of recommendations based on the research more maybe in the question time, if that would be good. And just to finish up by saying thank you so much to the Irish Cancer Society and the NCCP for supporting this research, and special thanks to Garrett and Katie, who really played such an integral role throughout the research study.
Thank you so much, Maria and Katie. That was a wonderful talk and really, really important insights into really recent research on kind of managing depression and cancer. And it's great to hear about all of that progress, and it's particularly great to see a showcase of how meaningful PPI can really make research relevant, and also a great example of conducting research ethically and with integrity. So congratulations on how you handled that systematic review and all those results. Thank you so much. And I can see two really interesting questions that have come in. In the interest of time, I'll ask those questions, but we might be a little bit brief in how we respond to them. And if there's any further questions, we can always pass them on to Maria at a later time as well. So I'll just read them out and get a quick response from either one of you, whoever would like to take this before we close out. So the first one is, if the existing evidence has such a high risk of bias, how will the HSE or other decision makers establish care pathways for treating depression, mental health in the immediate future? In the absence of trustworthy randomized controlled trials, what information can they use to underpin their decisions, or will this treatment be overlooked?
So there's a lot in that question. Katie, do you want me to have a stab first?
Please do, Maria.
Sure. So I suppose it's really important to reiterate that the findings from the review don't mean that these treatments aren't effective. So we know that they work for many, many people. but that the research evidence that underpins them, specifically in the cancer context, is not where we want it to be. So we do need higher quality trials for this. But we have many, many really experienced clinicians who are experts in psycho-oncology care who have been making good treatment decisions for years. We just probably don't have enough of them. So we do have a lot of evidence from other patient cohorts around the effectiveness of these treatments. And we do know, based on people's clinical experience who are working in psycho-oncology care for a long time, that they have the expertise to really decide for a patient, for a given patient, what are the factors that are contributing to their unique symptom profile, and based on everything else that's going on in their lives, to make the right decision for that patient. And really what came out of the qualitative study as well is that, patients are really happy to try any approach that is available and offered to them. And they found, value in most approaches, but sometimes the timing really mattered, and what was contributing to their depression at that moment in time. And that requires expertise. So you need psycho-oncology expertise to make those decisions. So it's probably something many GPs don't feel equipped to do. So it really supports, that you need this collaboration and communication between different healthcare professionals who are treating a patient. So we do need trustworthy RCTs to inform our decision making, but that's not to say that decision making at the moment is flawed in any way. We have experts who are delivering really good mental health care and support for depression for patients who have experienced cancer. But at the moment, those clinical decisions are largely made on literature that isn't cancer specific, but it's also based on a wealth of clinical expertise that is really valuable and shouldn't be overlooked.
Thanks so much, Maria. That was a complex question and a great answer. We have a second one here, and that is, do you think the so-called get on with it attitude that might be specific to the Irish macro system impacts the way we view and treat depression in Ireland? And again, either one of you is very welcome to respond to that.
I don't think it's an Irish problem. So I suppose in terms of the literature that we reviewed, it came from all over the world. So in terms of, the research, the quality standard, it's something that affects researchers globally. I think, we need to, I suppose, learn from this and move on. We need better quality trials, and it's not just about identifying interventions that work, but it's also about implementing them in clinical practice. So we need to make sure that I suppose the best interventions are the ones that patients use and engage with. And we need to make sure that the interventions that we offer and the treatments that are available to patients can be integrated in the healthcare system, and that they're accessible to clinicians and to patients, and that there is an awareness of all of the different treatment approaches that are available. Because a lot of the time it kind of fell to people weren't aware of the resources that are available, and there are lots of resources available, but they weren't necessarily clued into those, and then weren't referring patients on.
May I say
Absolutely.
here,
yes,
that I do think that the experience of cancer in the general public is seen still as a physical issue. So it's a bodily. Something is wrong with some part of the body, and the existential crisis of having some part of your body malfunction, and it affects your whole being. And I'm not sure that is fully appreciated in society, or even in medical care, in that the focus is on fixing that part of the body that's not working, and the overall recognition that this is an existential crisis. You may no longer be able to work. You may no longer even have the energy to work. And that isn't just because of your treatment, because you're depressed, because your own sense of yourself in society, in your family, in your job, has been rendered. It's collapsed, and you don't know who you are anymore, and you can actually question your value to society, your value to your family, your value to your friends, because, and I'm not sure that that is fully appreciated. And so that feeds into that whole qualitative study implications of, how seeing the patient as being much more than the illness in the liver or the illness in the bones or whatever it might be, is not fully appreciated. And if that was seen from a medical point of view and also from a societal point of view, it would help enormously.
Yeah, thanks, Katie. That really came out in the qualitative study as well. This kind of view as the physical cancer is paramount, and that everything beyond that was secondary, but it was so important to patients. And it really struck me. Some patients were saying that that they would go through the treatment again, but they would never want to feel the way they felt again because the impact was so profound, and they found the impact on their mental health nearly worse than the impact of the cancer and the treatment. And I suppose there was a sense sometimes that they felt that they had kind of maxed out on their kind of illness quota in a way that, that they had been through the cancer diagnosis and the cancer treatment, and there was this real expectation for them to be well after that. Sure, isn't it? So many months since you've had the treatment, and very little recognition of, that the impact of that can be weeks, months, years after a cancer diagnosis. And for many patients, the mental health impact really only emerged maybe a couple of years afterwards, but it really wasn't recognized. And people, yeah, this kind of expectation to get on with it. But I don't think it's unique to Ireland. I think it's probably the case in many different countries and cultures, where we're still prizing physical health over mental well-being.
Thank you. Yeah, it's a really, really important point to raise, Katie. Thank you. And it just goes to show how important and timely and relevant this research is. So thank you both so much. And thanks to the entire team for conducting this research. In the interest of time, we might wrap it up here. So I'd like to thank you again to our wonderful presenters, Dr. Maria Pertl and Katie Burling, and to all of you for attending. A recording of this webinar will be available for anyone who was unable to attend or who had to leave at 1. And if you have any further questions, you can email us at research@irishcancer.ie. Okay, thank you again, and thank you to everyone who's been here. We hope to see you soon. Okay.